Brown-Sequard syndrome is caused by a damage to one half of the spinal cord or a hemisection of the spinal cord. It can occur due to a tumor compressing on one side of the spinal cord or due to trauma, such as a penetrating knife or a gunshot. Now, the presentation of the Brown-Sequard syndrome will have to do with what we explained in the previous 3 lectures. So if you haven't watched them, make sure to check them out. The patient will present with some findings at the same level of the spinal cord lesion and other findings below the level of the spinal cord lesion. At the level of the spinal cord lesion, the patient will have loss of all sensations on the same side of the damaged half of the spinal cord, and a lower motor neuron lesion of the muscles supplied by the affected segment. And as we remember from previous lectures, the lower motor neuron lesion presents with hypotonia, hyporeflexia, and flaccidity. The spinothalamic tract will be damaged, so there will be a loss of pain and temperature. The dorsal column will be damaged, so there will be a loss of pressure, vibration, proprioception, and fine touch, and the corticospinal tract will be damaged, which will present as a lower motor neuron lesion at the level of the lesion. On the other hand, the presentation of the Brown-Sequard syndrome below the level of the lesion will present with a loss of all sensations on the ipsilateral side or on the same side of the lesion, with the exception of pain and temperature. Because as we can remember from previous lectures, the spinothalamic tract, which is responsible for pain and temperature, decussates or crosses to the opposite side shortly after entering the spinal cord. So a lesion in the spinothalamic tract will present contralaterally below the level of the lesion. The other sensory tracts, however, decussate upwards at the caudal medulla. As for motor affection, the Brown-Sequard syndrome will present with an upper motor neuron lesion below the level of the lesion. And as we know, an upper motor neuron lesion presents with hypertonia and hyperreflexia. And finally, if the lesion occurs above the T1 level, it can damage the hypothalamo-spinal tract and cause an ipsilateral Horner syndrome, which presents with ptosis, anhidrosis, and meiosis. And this takes us back to our previous lecture, when we said that the hypothalamo-spinal tract descends from the hypothalamus to the lateral horn of T1 and then goes up again to the level of the carotid bifurcation at C4. So basically, anywhere above the T1 level is a place where the hypothalamo-spinal tract could get affected. So in addition to the findings we mentioned, if the lesion occurs above T1, the patient may also present with Horner's syndrome. So to quickly recap, the Brown-Sequard syndrome is a hemisection of the spinal cord that can be caused by a compressing tumor or trauma, and it can present with findings at the level and below the level of the lesion. At the level of the lesion, it presents with motor and sensory affection. The motor affection involves the damage of the corticospinal tract and presents with a lower motor neuron lesion at the same level and ipsilateral to the lesion. The sensory affection involves the damage of the spinothalamic tract, which presents with a loss of pain and temperature ipsilateral and on the same level of the lesion, and involves the damage of the dorsal columns, which will present with a loss of fine touch, pressure, vibration, and proprioception ipsilateral and on the same level of the lesion. Below the level of the lesion, the motor affection is represented by an upper motor neuron lesion. The sensory affection presents with a loss of fine touch, pressure, vibration, and proprioception ipsilaterally, and a loss of pain and temperature contralaterally. And if the lesion occurs anywhere above the level of T1, there could be an affection of the hypothalamo-spinal tract, which can present with an ipsilateral Horner syndrome.